Assalamu alaikum, the clinical day. The first scenario, Mrs. Julia Adam, 35 years old, female, with a history of 3 months with complaint of headache. For your kind care, please take history, examine, and address her concerns. Dr. Yasser,
Okay.
if you are ready, we can start.
Yeah, we can start, doctor.
Yeah. Okay, I will share the
Okay.
timer, then you can.
Okay. Good evening. I'm Dr. Yasir. Can I confirm your name and age, please?
My name is Julia Adam. I am
Okay.
35 years.
Okay, Miss Julia, I came to know that from your note that you have problems of headache. Can you tell me more about it?
Yes, actually, I have this headache for the last 3 months, and I feel it is more getting worse than before.
Okay, I'm really sorry to hear that. What is the nature of the headache?
It is dull.
Dull. Any particular side of the head?
It is mainly on over my forehead.
Over your forehead. And how do you like to give to your headache?
I take some analgesics to relieve, but also to be resistant.
No, doctor. A score among 0 to 10. How much score would you like to give to your headache? 10 being the most severe pain you
Yeah,
have ever gone through, and
yes,
1 being the
it is about 7/10.
7 over 10. This is the first time or before also used to have the similar headache.
No, this is the first time since this 3 months.
Okay. Does it go anywhere?
No, it is only in my forehead.
Anything which makes you feel better regarding your headache?
When I come up from my bed, I feel it is better than sleeping.
I mean, when you come out of the bed or what?
Yes, it is better when I come out of of the bed.
Okay. Anything which makes it worse?
When I sleep, I feel it worse. And also, last week I have a common cold. I feel when I have this cough, this headache is increasing with this cough.
Okay. So you are trying to say that when you are lying down, your headache is more. When you stand up, your headache is less, right?
Yes.
Okay. And are you diagnosed with any medical condition that I should be aware of?
No, I don't have any previous medical condition.
Okay. Taking any medications?
Uh, Medications, some vitamins I received before,
Mm-hmm.
and also last 3 weeks I went to the skin doctor, and he
Mm-hmm.
prescribed it for me some antibiotics because of the I have some acne in my
Okay.
face.
Okay, which antibiotic? Can you show me the list?
Yes, he gave me minocycline.
Minocycline. Okay. When did you start taking this minocycline?
I received it for about 7 days. I finished 2 weeks back.
I mean, your headache started 3 months back, but this minocycline is you started to take only 1 month before 1 month.
No, I received this minocycline from 3 weeks. I received it
Three
for
weeks.
1 week only. So 2 weeks and now finished this minocycline.
Okay. And there is are you are not taking minocycline no more? You are taking it.
No. Now I finished already this antibiotic. I'm not taking now.
Any history of the hypertension?
Hypertension? No, I don't have hypertension.
Any vision changes? Vision problem?
Sometimes I have blurring of my vision. It
Mm-hmm.
comes and go. It is
Mm-hmm.
sometimes, but I feel before the 3 months I don't have this blurring. So maybe it started with the headache. I don't really sure.
Okay. There is pain in the moment of your eyes.
No, I don't feel movement. No, pain.
Okay. Okay. Any weakness anywhere?
No, I don't have.
Any tingling, numbness anywhere?
No,
History of the fits before?
no, I don't have fits.
Okay. Did you lose the control over bowel and bladder anytime?
No,
No. Uh, okay. And is there any weight changes?
weight changes. No, I don't have weight changes.
Weight changes. Okay. No, no snoring. Have you been told by your family members that you snore at night?
Snoring at night? No,
Yeah.
no,
No.
nobody told me regarding this.
Okay. No, no weakness in the morning. No, I mean dizziness in the morning.
No,
No. Okay. And do you have any chest pain?
no,
Any racing and pacing of the heart?
no.
Any cough?
Just this common cold, but now it is improved than before.
Okay. Any wheezy chest, noisy chest?
No,
No. Okay. Any neck swelling?
I don't have.
Any lumps and bumps anywhere?
I have not noticed anything abnormal in this bumps and
Okay.
lumps there.
Okay. Any weather preferences?
No, I don't have.
Okay. Uh, no. Any joint pain?
No,
Any skin rashes or is any other skin conditions?
skin rash. I have this acne I told you regarding.
Okay. Okay.
It is
Other than that.
improved than before. I have not
Okay.
noticed just this acne.
Uh-huh. Okay. And what about your bowel habit?
No abnormality.
Any tummy pain, tummy distension?
No, I have not noticed the abnormality in my tongue.
Any difficulty in swallowing?
No,
Any acid breath in the mouth?
no,
What about your bladder work?
no. I have no problem in my water work.
Okay. Uh, Other than your this paracetamol sometimes and minocycline, taking any medications, any other than this?
No, this medicine that I told you and I have finished. This analgesic, I took this diclofenac.
Diclofenac. Okay.
Yeah.
Oh, since when you are taking diclofenac?
No, just this is when there is severe headache, I take just one only. This is over the counter, not prescribed by the doctor.
Not taking regularly.
No, 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 just on need. When I feel
Okay.
severe headache, I take one. Yeah.
Fine. Any significant family history that I should be aware of?
Any what doctor you mean?
Family history.
Family history?
Yeah.
No, I don't like my condition. We don't have this
Okay. Did you travel anywhere recently?
travel. No, I went to Yorkshire just last week. I am here in London now.
Okay. Okay. Any fever?
I don't have fever.
Okay. Any needle shearing, tattooing, anything?
No, no,
Okay. Any history of the blood transfusion?
no,
Okay. So, do you smoke?
no. I don't smoke.
Do you take alcohol?
Take alcohol. You
Yeah.
mean no? This is also only social drinking. I'm going at the weekend only.
What is your job?
I am a secretary.
Do you feel this condition has affected your professional life?
Yes, the severe headache affecting my work. Yes, I took many sick leave because of this headache.
I'm really sorry to hear that. And if you want, we can try to take help from the occupational health worker in this regard. Do you drive?
Okay.
Do you drive?
Drive? Yes.
Okay, for the time being, we need to. I think you need to stop driving, and later on, after confirming your case, we can tell you when we can resume your driving. Is it all right?
Okay.
Okay, can I examine you?
Okay. What you want to examine?
So examinations first from the pronator drift.
Okay, it is normal.
This is negative. Okay, in the eyes, doctor. Uh, Equity
Acute, it is normal.
field.
It is normal also.
Field is also normal. Okay, heart and lungs. Heart.
No abnormality. Heart, no abnormality.
Okay, this one carotid breath.
No carotid breathing.
Okay, lungs anything.
Lumbus, no,
Lungs,
no,
lungs.
no. Lungs, normal.
Okay, anything in the pulse BP.
BB is 135 over 85.
135 over 85, and your pulse is
It is 90.
90. Anemia, sinuses, jaundice, anything.
Anyone?
Anemia, sinuses, jaundice.
No, no, no. No jaundice.
No facial symmetry is fine.
No abnormality in the general.
Okay, and out in surrounding anything. Walking aids, anything.
No, no, no. No walking yet.
Okay, so what is your concern?
My concern, I have cancer, doctor.
Why do you feel you have cancer?
I don't know because I have this severe headache and
Okay,
I don't know this severe headache be resistant and may I have cancer? I am afraid to for this.
okay. So from the conversations we had and the examinations I did with you, I think it is very unlikely that you might have cancer. But having said that, we need to rule it out. But from the there are other possibilities in my mind. Okay, so it could be the I don't have the it could be what we call the idiopathic intracranial hypertension. Don't bother with the medical term. Okay, this is the condition where there is more pressure in the fluid inside your brain, causing the kind of the headache you have. And recently you took one of the medicines for your acne, what we call the minocycline, that might have exacerbated this condition also. So we need to rule it out. And other possibilities also we need to rule it out, Mr. What is your name?
So
Mr.
yes.
Yeah,
So you are telling me I have some idiopathic intracranial hypertension. Can
yeah,
you illustrate what is this? I don't understand this term, doctor. Please.
2 minutes left.
yeah, yes, that is the thing I told you. No, this is the fluid in the covering layer of your brain, and inside your brain,
Yeah.
the more pressure due to the formations of the more fluid, or due to other reasons, it is creating more pressure inside your brain, causing the headache you have. Did you understand?
Yes, but really it is difficult for me because really
Hmm.
I am stressed because of this condition. I don't know how will be my outcome. I will improve or I will
Yeah.
deteriorate more. I don't know really, doctor.
Yeah, yeah. I really appreciate your concern. So, and you have the problem in the vision, and you have the severe headache. So, what is my plan is, I'll admit you now, and you need to stop driving. You need to stop that minocycline medicine for the time being. We'll form the multidisciplinary team, including the brain doctor, including the skin doctor, uh, and other.
Hmm?
So we'll go for some the blood test, camera test. Okay, maybe the we might also need to take the fluid from the back from your back to go to know to know more about your condition. And once we have the definitive, more definitive diagnosis, I can tell
Okay.
you more
Okay,
precisely
doctor,
what can be done.
sorry, doctor, why you will make camera test for me? I'm afraid regarding why this.
A camera test means, in your brain there might be something. Okay, so it is better for you for us to rule out.
Okay,
Okay, time is
Okay.
up. Yeah.
So do you have any other concerns? Sorry, doctor.
thank you,
Thank you, doctor.
thank you.
Yeah.
Okay.
Okay,
Well done, Dr. Yasser. Let's go to the exam question. Can start now, Dr.
okay. Just present your finding.
Okay, this 35-year-old man came with the complaints of the headache for the last 3 months. The
Yeah.
patient has the history of the acne for which she has prescribed the minocycline, and the nature of the headache was dull, which increased aggravated on lying down and get better with the standing. And and there was and she has the problem in the vision also, which was on and off, and no other symptoms. So on the in this and in the examinations, I didn't find any positive findings. On the basis of the history, it goes more with the idiopathic intracranial hypertension.
Okay. What is your differential diagnosis?
Could be sphygmomyosin lesion also, and could be idiopathic intracranial hypertension or sphygmomyosin lesion,
What
and
else?
what else? Medications I cannot say here because this is on and off.
Okay. If I extended another minutes for you in this examination, what else you wanted to examine?
Neurological examinations I like to do, doctor.
Okay. What else?
Uh, Neuro and what? Any skin was not there, not neurocutaneous, idiopathic. Eyes, eyes I did.
Eyes. What else in the eyes you did? You should do.
A fundoscopy, doctor.
Yes. Excellent. Okay.
Yeah, yeah.
What investigations you will do for this patient?
So baseline investigations in the form of the complete blood count, inflammatory marker, CRP, ESR. And then for the confirmatory, here we can go for the MRI of the brain, and also CSF, spinal pressure, we can see. Other than that, routine tests, liver function test, kidney function test, urea electrolytes. These are important.
Okay. What else?
What else? Then perimeter for the vision. I think perimetry you can do. Then for this one, what can we do, doctor? Mm,
Okay. I will tell you. Okay.
okay.
So, what is the treatment you will give for this patient?
Treatment is non-pharmacological. Education is important here. Stopping the medicine is important. Minocycline, aggravating factors like this one, minocycline. Stopping the driving is also paramount. Other than that, in medications, we can give the acetazolamide, furosemide, and the simpler analgesic paracetamol we can give, and we can do go for the repeated LP, and surgical intervention is also available in the form of BP shunt. BP shunting can do.
Okay. Okay. Thank you.
Thank you, doctor.
Thank you. For this, we have to answer 30 minutes.
Still,
What
yes, yeah.
other?
Give him
Yes,
more question, please, Dr.
yes. Regarding this headache, because you told because this is idiopathic intracranial hypertension. Okay. What other headaches you have excluded in the history if there is no intracranial hypertension?
So, fever, I
Fine.
mean, infections I excluded.
Yes.
Then acute headaches I excluded.
Okay.
Then sinusitis I excluded.
Okay.
Then then other
Giant cell arteritis. Giant
neurocutaneous I
cell.
excluded.
Okay. Giant cell arteritis also
Giant
you
cell
excluded?
arteritis,
Yes.
I young patient, no fever. I that's why it was better to exclude that one also. And this
Because
was
there
a
is
long duration, doctor. Three months headache. Giant cell artery is less likely is acute headache.
Okay.
So I didn't
Okay.
consider that.
Okay.
And
Excellent. Yes. Excellent,
those
doctor.
are, and then hypertension also I excluded. Those and OSA, hypertension, neurocutaneous,
Okay. Okay.
and
Excellent, doctor.
thank you, doctor.
Excellent, doctor. Okay. So I will, if Dr. Bassam will allow me to comment, or
Yeah, what are the risk factor for IIH in this patient? So that's the last question, Dr. Ahmed. Sorry.
okay.
Uh,
Because yes, what is the risk factor here?
Weight was not much changes, doctor. Weight, there is no much change. One is only minocycline, doctor. I didn't find anything else.
Okay. Okay. Just to comment, because you asked in the history regarding the weight changes. There is no weight changes already, but this patient already overweight. So you should ask
Okay.
regarding the vital signs of this patient and also the body
Um.
mass index. Just fix in your
Okay.
mind.
Okay.
Also, I am
BMI, I
forgetting
didn't
this.
ask. Yes, doctor. You're right. Yeah.
Yes, yes. Vital signs. Give me vital signs and give me the body mass index. This patient
Yeah.
already obese. So this obesity is a risk factor, and also this minocycline also is a clue for you. And this increased intracranial hypertension. It is you from the history because it is getting worse by coughing and also while sleeping. Okay,
Mm-hmm.
so you get this point.
Yeah.
On the examination that I told you, this is important, the body mass index. Then you should ask for this fundus, even you find the acuity
Mm-hmm.
and the field it is and the movement it's okay. You should tell the
Mm-hmm.
examiner I wanted to do fundus. Mostly he
Mm-hmm.
will tell you no need, mostly,
Yeah.
but it's
Yeah.
important also to be done in any headache. You should offer
Yes.
this fundus. Okay.
Mm-hmm.
Other thing, when you asked me regarding the family history, I told you of my condition. So
Mm-hmm.
there is you should also ask regarding the thrombophilia because cerebral vein thrombosis is also a
Mm-hmm.
headache with increased intracranial pressure. So
Yeah.
increased
Absolutely. But there
intracranial
was no
pressure.
fever,
Yes.
doctor.
No. And regarding the cancer history in the family.
Yeah. Yeah. Cancer is important.
Yes.
Yes.
Yes. Yes.
You need to ask
Idiopathic.
particularly. Okay. Cancer history.
Yes.
Yes. Very important. Okay.
Yes,
Yeah.
idiopathic and specific occupying lesion, okay, and
Mm-hmm.
also the cerebral vein thrombosis, okay.
Mm-hmm. Mm-hmm.
So also in the investigations, you mentioned it is nicely. You should add the MRV, the magnetic resonance
Mm-hmm.
venography to exclude the cerebral vein thrombosis,
Mm-hmm.
okay.
I was not
On
thinking that because the absence of the fever and no painful eye movement. That's why I
no.
didn't. But it's still
MRI
better to exclude.
will do both. Will do both MRI and MRI venography. Okay,
Okay.
but both
Mm-hmm.
should be done. Okay,
Mm-hmm.
lumbar
Fine.
puncture it's okay. So
Mm-hmm.
and the lumbar puncture will do also the measure the pressure and we will see
Pressure.
also there is microscopy. Okay.
Mm-hmm. Mm-hmm.
Treatment as you told will be treatment of the cause like reduction of the weight, stop
Mm-hmm.
medication, and you did it nicely. This is excellent that you told acetazolamide, repeated lumbar puncture, as you said.
Yeah.
Also, the surgery, shunt or optic nerve administration,
Mm-hmm.
they are doing. Okay.
Mm-hmm.
Giant cell arteritis, it is excluded because this is in the forehead, mostly this is bitemporal, this idiopathic. Giant cell, it is also mostly it will be unilateral. Sometimes you will find the features of polymyalgia rheumatica, okay, and this patient he doesn't have. Okay.
But two, three factors were negative on that front, doctor. One is age,
Yes. Yes.
another was fever, and then not acute. That's why not episodic. That's why I
Yes.
didn't think about that.
Yes. Yes. So this headache, it is either acute or either chronic. Uh, for this
Mhm,
patient, acute, it will be within 1 month.
mhm,
There is to come with new character. So now it is 3 months, so it is considered chronic. Okay. As regard the acute headache, we have the subarachnoid hemorrhage. You have the cerebral vein thrombosis also. So it can be put on the acute and the chronic. We have the meningitis. We have the giant cell arthritis. Okay. As
mhm,
regards the chronic headache, we have it can be continuous or it can come in attack. An attack like a migraine cluster,
mhm,
chorocytoma. If continuous, we will see it is with increased intracranial tension or no increase in intracranial tension. If increased intracranial tension, we have the three differentials, this occupying lesion, or cerebral vein thrombosis, or the idiopathic intracranial tension, like in this case, hypertension. Okay, no increase in intracranial pressure, and it is continuous. We have the
mhm,
tension headache. We have the polycythemia rubra vera,
mhm,
which having skin itching increased by the
mhm,
hot bath. We have the obstructive sleep apnea, and you did it, headache in the morning,
mhm.
but it will not increasing with the cough and sneezing like this case. Okay, we have the analgesic overuse headache, and you will know by the analgesic he is using maybe 10 or 15 days each month for 3 months, like that one. Okay, so you did it nicely, Dr. Really. Yani,
It was
excellent.
better to include tension headache also, doctor. I forget to exclude that one.
What?
Tension headache,
Uh,
doctor.
medication overuse headache, you mean?
No, tension, doctor.
Yes, yes, tension headache also. But headache, there is no signs of increasing because this headache is increasing by cough.
Yeah,
So
yeah.
so the differential only you miss is the cerebral vein thrombosis. Tension
Okay,
headache,
doctor.
if there is, it is continuous, but there will not be increase in the intracranial pressure. Okay.
Yeah, 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 doctor.
Okay. So excellent, doctor. You did it nicely, really.
Thank you, doctor. Not nice, actually. Okay, only.
Okay, thank you. No, you did it great, Dr. Yasir. You were systematic and organized from the start till the end. Although you missed some points, but it's not against the perfection, or at least you did it as Dr. Ahmed said, in great way. Thank you, Dr. Ahmed, for the case. But let's
Welcome.
have a look to the chat box. This is the collection of paces headache or headache and paces.
Mhm.
So in the chronic form, I think cerebral venous thrombosis, it might be more acute than it should be
Yeah,
like chronic.
yes.
Yeah, so
Two, three things.
maybe subacute, but it will not be chronic.
Yes. And two, three things will be there, no, doctor. One is the movement of the eyes and fever. Those
Yeah,
things should.
exactly. Yeah. So what I wrote in the chat box, you can see the differential of chronic headache with an increase
Uh-huh.
in tachycardia pressure,
Uh-huh.
as in our case, idiopathic intracranial hypertension
Uh-huh.
and brain abscess, space occupying lesion, pituitary adenoma. Why?
Yeah.
Because there is a mass or something
Yeah.
occupying or increasing occupying the spaces and increasing the intercare pressure by this mechanism.
Uh-huh.
But the tension headache, the migraine, all other
Mhm.
causes, it would be without
Episodic.
increased intercare pressure signs. The good thing
Yeah.
here, you ask about the signs of increased intercare pressure. So whenever you have
Mhm.
them, think
Mhm.
about the other causes of increased intercare pressure and roll it out
Mhm.
one by one.
Mhm.
So we have to know the alarming signs or signs of increased intercare pressure. Already it was mentioned by Dr. Ahmed. That's why he helped you to reach to the
Mhm.
diagnosis when he told you, when I cough or when I had
Yeah.
common cold last week, the cough make the headache worse. So
Yeah.
it's a clue for signs of increase in tachycardia pressure. You can ask
Mhm.
other question for signs of increase in tachycardia pressure, like the headache worse with the leaning forward, and
Mhm.
the also papilledema signs and symptoms. So you can uh, have more clues about the signs of increase intracranial pressure.
Yeah.
Apart from that, the constitution symptoms you have to ask together rather than asking the fever separately from the
Uh-huh.
constitutional symptoms.
Uh-huh.
So the increased weight, or sorry, decreased weight, any loss of weight, loss of appetite, lumps or bumps,
Uh-huh. Uh-huh.
night body temperature, or night sweats. These questions, try to ask them together. If you have
Yeah.
positive, these questions or answer of this question, you could think
Mhm.
about what? If you have positive, for example, night sweats,
Yeah.
increase temperature, what it can give you a clue.
TB.
Infections, right?
Yeah.
Infections, tuberculosis,
So
HIV.
yeah, not only HIV. From our differential, I wrote down.
Meningitis,
So what do you think?
encephalitis.
Encephalitis, it would be acute, right? It wouldn't be as a chronic.
TB
Yeah.
TB or lymphoma.
TB.
Brain abscess, or
Vesicular lesion.
space occupying lesion. Yes,
Yes.
these are the cause of increased incubation with constitutional symptoms, as a tumor or infection. Brain
Yes.
abscess, one of the differential, or
Mm.
space occupying lesion.
Yeah.
So you
Right.
can ask like in this way: if you have positive constitutional symptoms, so it's going with something, either serious infection
Mm-hmm.
or malignancy or tumor.
Mm-hmm.
In our patient, you can ask about the weight. If the weight is increased, or she notice her weight is high, you can say
Mm-hmm.
it's related to the obesity. And as I wrote in the chat box while doing examination, before examining the signs of the patient, examine the surrounding.
Mm-hmm.
What are the surrounding? Any wheelchair? You might have wheelchair, and you have to
Yeah.
notify
Why
it.
writing that, doctor?
The walking aids. Yeah, you didn't find, but I mean, before starting examining,
I thought it's
why?
someone was writing. Yeah.
Yeah, it's important. You start to examine the patient directly without even vital signs.
Yes. Yeah. That
So
is not.
try to have a look to the
Uh-huh.
patient
Uh-huh.
at the end of the bed, the
Mm-hmm.
surrounding, then the general
Mm-hmm.
look, how the patient look, increased body mass index, or some characteristic features. You have to notify this to the examiner.
Mm-hmm.
Why? Because in this patient, you have to mention the body mass index particularly. It's one of the risk factor for increase in tachycardia pressure, right?
Yes, doctor. Sure.
Yeah.
Definitely.
Plus the acne, you can notify from the end of the bed. At the end of
Mm-hmm.
the bed, you can say, yeah, the patient has some acne in the face, plus the obesity. So we have two risk factor.
Mm-hmm.
Then the other risk factor you can get from the history, OCP, patient is taking OCP, or
Mm-hmm.
some antibiotics.
Okay.
Steroid as well can be one of the risk factor. You can ask
Yes.
particularly about the steroid itself
Mm-hmm.
or any other medication. Otherwise, you did great history taking, systemic review, but I would like to analyze the CNS more, about the speech, about the sleep, about the memory, about the hearing. Put them in
Mm-hmm.
your mind. Some patients will have neurological deficit because of the headache itself,
Mm-hmm.
regardless to the case, this case, I mean. So try, if you have any CNS complaint,
Mm-hmm.
analyze the other CNS manifestation,
Good.
change of the vision,
Mm-hmm.
or change of the speech, change of the hearing, the sensation, the weakness, balance
Mm-hmm.
itself. Patient might have unsteadiness, and you might have a case of, for example, NPH, normal pressure hydrocephalus, in elderly patient. If you
Uh-huh.
just remember the unsteadiness or the gait of the patient.
Yeah.
Okay, so don't miss those things while asking detailed history of the relevant system, which is here the CNS system.
Yes.
Okay, it's clear now, right?
Yes, doctor. Thank you very much, doctor.
Yeah, the others you did great about loss of control, about the bowel or water work, the GI, the chest, weather preferences. You did them in systematic way, from up. What I prefer, from up downward, till the end of the system review, the skin rash, and the joint pain. uh, family history, you address the travel, the medication. I
Only
prefer.
female history, I think we should also ask.
Yes, exactly. You have to ask about the female history here. The P is very important. The OCP, one of them, birth control pills, pregnancy, and the periods.
Yeah.
Any patient in the childbearing period, you have to ask these three questions, three P's: period,
Yeah.
pregnancy, and birth control pills. Thank you, Dr. Ahmed, for the adding point. I think we have discussed, yeah, the social also you did. Do you smoke? Do you drink alcohol? And address them immediately. If you have any positive, you have to address them. Here
Mm-hmm.
you didn't miss. I think
Mm-hmm.
why? Because you went systematic. If you ask question from here and there, you will miss something. But since
Yeah.
you ask about the do you question, do you smoke, do you drink alcohol, do you drive, what's your job, you asked all the question related to the social, plus the impact of your symptoms on your job. For me, if even you didn't reach diagnosis, you can get a full mark. But the examination should be more detailed about the CNS. The papilledema, you have to offer the fundoscopy. Even you will not do, offer the fundoscopy, the visual field, the visual acuity. Try to do the examination steps in details, starting from pronator depth as you did. But before pronator depth, ask about the blood pressure. The patient might have metabolic syndrome, obesity, so it might be associated with metabolic syndrome, right? So you have to ask about vitals, blood pressure, the pulse itself. If there is obesity, you can check for carpal tunnel. It might be associated. Then the pronator depth as CNS, you can offer tone power reflexes if you suspect some weakness, but here it's not the case. And the CNS in the face, you can ask about the vision. Because of
Mm-hmm.
blurring of vision, you have to offer acuity fields and ended by the fundoscopy. The acne, you have to notify them, the
Mm-hmm.
mouth, and you have to roll out OSSA here because of the obesity as well. We should roll out obstructive sleep apnea, large
Yeah.
tongue, large mouth, the large neck. You can ask for measuring the neck circumference. Then for the other body, I don't think you will have anything positive
Mm-hmm.
apart from the obesity itself.
Yes. BMI, it was not in my mind at all, doctor. It should
It's
happen.
okay. It's okay. You learn now one information which is important
Yeah.
to be positive in IIH, which is the body mass index. So next time, if you have this case in the exam, you will remember this case and this practice.
Yes. Thank you, doctor. Thank you very much.
Most welcome, Dr. Yes. Any question from you?
I think that's it, doctor. I mean,
Yeah.
yeah, great, doctor.
Okay.
Thank you.
Dr. Ahmed, you have any question? Thank you. Can you write the case in the chat box?
Oh, chat.
Yeah, please. Dr. Ahmed, any question or added point or comment?
No, 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 thank you very much. Appreciated
Okay,
really,
be
Dr.
ready
Bassel,
for
for
yeah.
mm.
Okay, be ready for your scenario. Just I will try to read any comment from others. Yeah, again, for medication, I wrote some points. Sometimes I'm writing in the chat box in order not to forget. Whenever you have over-counter medication or medication patient is taking by himself without GP prescription, please try to know for how long and what the frequency. You might have a case of medication overuse headache. Of course, not this case because medication overuse headache, the patient will not have increased intracare patients. But please roll it out by asking since when you are taking and how frequency you are taking. Why? You might put it in the differential if the patient is not having increase in the care pressure. For example, maybe the patient for 3 months he's having headache of overuse headache, medication overuse headache. But lastly or recently, the patient headache change, the nature of the headache change. So the patient has a new pathology, which is increasing the care pressure, for example. But previously he was having medication overuse headache.
Mhm.
Okay, it's clear now, Dr. Yasser.
Yes, doctor. Yeah. Thank you, doctor.
you have to ask in any over-counter medication history, ask about the duration
Mhm.
and the frequency. Do you know the definition of medication of overuse headache?
I think analgesic
When you yeah,
for 2 weeks, at least 2 weeks, doctor. I think
2 weeks for
or NSAIDs. I think
okay. So you have two types, either opioid
or NSAIDs.
or NSAIDs. Yes, the opioid will
Mhm.
be
I
every
don't know, doctor.
month. Yeah, every month more than ten
More
days.
than for
10
3 months.
days for 3 consecutive months. Yes.
Fine. Okay.
For non-steroidal, 2 weeks. We
Mm-hmm.
said the opioid 10 days, right? Here 2 weeks.
2 weeks.
Yeah, per month for 3 consecutive months.
Okay, doctor.
So you
Thank
have
you.
to know since when the patient started on and how
Mhm.
frequency he's taking it.
Yeah. Yeah.
You might put it as a differential, or it might be the case itself.
Yes, I think it was online, doctor, because I asked about the frequency and the durations. It was not fitting to the criteria.
Yeah. You ask, but you didn't ask since when you are taking. You ask him how frequency, and he told you, yeah, I'm taking on need, right?
Yes,
Yeah.
sure. Better to dig a
Yeah,
bit deeper.
ask more. Yes, exactly.
Mhm.
Is it more than 2 weeks or just on need? He might take it on need every day.
Yes, yeah, you're absolutely right, doctor. Yeah.
Okay. Any other question? Yeah, someone added here, Dr. Abu Ahmed. Cranial nerve examination. I
Mm,
agree. If you have suspicious of, for example, sixth or third nerve palsy, this is what you want to say, right?
maybe yes. Six
Yeah,
nor with it.
exactly.
Six
Six
nor.
and fourth, and yeah. So the nerves or cranial nerves responsible of the eye movements. But
Yeah.
if you have diplopia or ophthalmoplegia, you can do so. However,
Mm.
yes, sometimes IIH can lead to a sixth nerve palsy, right?
Yeah. Idiopathic intracranial hypertension can lead, yeah, six nerve.
Exactly. Yes, exactly. So yeah, you can offer the H-shaped movement
Mhm.
while doing examination of the eye. Other
Yeah.
cranial nerve, I don't
Not.
think, yeah,
No.
it makes sense to examine them.
Mhm.
However, if you suspect, for example, brainstem or schwannoma or the tumor in the cerebellopontine angle, you can
Mhm.
offer them. But it's not the case here.
Yeah. Not this. Yeah.
Okay. Did you write the yes, Mr. John, 30 years old, with history of heart attack
In the morning.
in the
Now.
morning. Yeah, now the patient in ER. Okay, good
Yeah.
start. Dr. Ahmed will give you two
Okay.
minutes to be ready.
Okay.
Anyone has comment or suggestion to be added?
Uh, yes,
Yes,
just
Dr. Aisha. Dr. Dina. Yes, Dr. Dina.
yes. I think his history may be deducted from marks because asking about it is related to a specific time of the day, morning or evening, and ask about symptoms of increased intracranial tension together. He didn't ask unless Dr. Ahmed gave him the information. Is it related increase with coughing, sneezing, clean throat? You mentioned all of that, and this is very important. And also other associated symptoms of increased intracranial tension, feeling sick, throwing up, blurry vision, neck
Perfect.
stiffness. Neck stiffness very important to exclude meningitis. All of these are red flags. And also, as you mentioned, Dr. Bassem, signs of focal neurological deficit, any loss of consciousness, any fits, any like that, any weakness, any
Yes.
altered sensation. His history he will not take the full marks on his history. uh, he should ask like that. Other than that, this patient is obese or overweight or increase in the weight. Could be Cushing or PCOS, polycystic ovary.
Yes.
So he should ask the female history. What about the cycle? What about the
Perfect.
are you is it because PCOS will not have cycle, will not be able to conceive or have to be pregnant. So female history. And the Cushing increase in the weight is related to specific part of the body.
Yes.
Any hirsutism, increase in the hair growth, like this.
Breezes. Yeah. Easy bruises. Yes, you're right.
Yeah.
This is the comment on the history and the examination. I'm weak in the examination, so you are you gave us what to examine in this case. You mean the eye? Can you repeat it in brief? The points for examination in this case.
Yeah. Any patient you want to start examination, always start by the surrounding. This is regardless the case. Surrounding, maybe particularly the neurological patient. You might have either wheelchair or walking aid, as in this patient. She might have eyeglasses because of vision or blurry vision. What I mean, check the surrounding before going to examine the patients. It's very important. They are focusing on the inspection. Now you finish, you will comment on the general look, or you have to have a look for the general look. Is she overweight, average weight, or she is underweight, cachectic, whatever. If we have brain or space occupying lesion, you might have patient with underweight, or for example brain abscess. Brain abscess also one of the cases. You might have underweight patient or cachectic patient due to constitution symptoms, right? So these things is very important before touching the patient, and
Yes.
you can gain a lot of marks. Now the time to examine the patient. When I start to examine, I will ask for the vital chart because they are writing outside the vital chart of the patient. So I want to know how the blood pressure, how the heart rate, how the temperature. Why in this patient blood pressure is important? As I said, it might be metabolic syndrome. Patient will have hypertension because she's obese. She might be also Cushing. She might be hypertensive due to Cushing. She might be hypertensive due to polycystic ovarian syndrome. So we have to comment on the vital charts. If you have suspicious of decrease or posture hypertension, ask the doctor or the examiner how about the posture hypertension or any change of the blood pressure from sitting to standing. This is not in this case, but I mean, always remember the blood pressure with
No,
the
and in
posture
this
hypertension.
case, if it's in pituitary adenoma or something, he may have this. And also,
Exactly.
yes, another thing, recurrent miscarriages to exclude any liability for thrombophilia condition. Like Dr. Ahmed said, the differential for this case will be cerebral venous thrombosis. The same symptoms like this condition, the same presentation. So Dr. Ahmed mentioned that you should do not only CT brain, but also CTV. I think so.
Venogram.
Venogram.
But for, for me, it would be more acute, Dr. Dina. The venous thrombosis would be presented as acute, not as a 3 months.
Yeah.
It would take more time, sorry, less time or shorter duration to be presented. And the headache will be severe with increased intracranial pressure. The patient even might have seizure.
Yes. Yes.
This and also you have other signs of like OCP or thrombophilia or whatever. But I think it's not differential in this scenario because you have 3 months history of headache.
Could
So
it
what
be
can give you?
yeah?
Yeah.
Could it be progressive, like small and like any DVT may be massive or
No. It would
like
be
that?
any thrombosis in the brain, either space or even the venous sinuses. It will be presented as acute
Mm,
all of a sudden, not as a chronic.
yes.
I
Okay.
didn't hear about chronic venous thrombosis.
Okay.
Okay. Yeah.
It's pretty popular, right? The
Sorry?
painful eye, this coughing strain is there, and acute. These are the, I think, three important things to rule out the cerebral venous sinus thrombosis.
Again, Dr. Yasser, what's the comment?
Painful eye movements.
Painful eye movement as venous sinus thrombosis. No, this is cavernous sinus thrombosis.
Cavernous sinus thrombosis.
Yeah, there is difference to care between cavernous sinus thrombosis and venous sinus thrombosis.
Mm. Yeah. I got it.
Yeah, yeah. So back to the examination, as Dr. Dina wants to know, you want to start as a neurological examination. If there is
Mhm.
any history of weakness, you have to examine the periphery, right?
Yes.
But in
Yes,
this
doctor.
patient, at least do the pronator drift just to rule out any stroke or something in the brain. Then the main important here to examine the eye.
Yes.
It started by acuity, the field, the H
Mhm.
shape, and the reflexes, and you will end by ophthalmoscope. These are the main presentation of this patient, right? The
Mm.
Yes, doctor.
papilledema,
Agreed.
or abducent nerve or sixth nerve palsy while doing the H shape.
Yeah, if you have
Apart
time,
from this, yeah, sorry,
that you can do.
yeah, but this is the most important to do. Otherwise, you will examine for acne. You will examine for the cause of the for the obesity, for example, like Cushing. If you have signs of Cushing, as Dr. Dina mentioned, but it might be just simple obesity or familial obesity, complicated by the medication like macrolide, and this
Mhm.
macrolide leads to, or tetracycline, sorry, leads to increased blood pressure or steroid history. So the trigger you have to know, or the
Mm.
complication of obesity like OSA, like carpal tunnel. So it depends on the scenario. What is the positive? Write always the positive finding in the history in your paper. Why?
Mhm.
Because you are gonna examine this thing while doing this examination steps. For example, if you hear like the patient is taking steroid for any medication, for any reason, you have
Mhm.
to examine the signs of Cushing,
Okay.
like
Extra.
erythrosis,
Yes.
yeah, like
It's,
stria, like yeah, interscapular fat distribution, plus the IIH as a visual affection.
yeah.
So it wouldn't be something to do particularly as IIH. It might be associated with another complication. You have to examine the complication. But for IIH, for me, the eye is the most important thing to examine. Started for the acuity and field and the H shape, reflexes, ended by ophthalmoscope.
Yeah. That's good enough, I think.
Yes, yes, right. Maybe OSA is another differential. OSA, yes, it fits the case.
No, doctor, because there was no complaints of OSA.
Also, yeah, also
No,
it might be as a complication,
yeah,
but
morning headache in a patient, an obese patient. It's a very as
yes,
morning headache. It's a very important differential.
Yeah, ask doctor, but he didn't give such history.
yeah,
I mean,
but
in your exam, there is marks for a scale called the differential. So you should have, in your case, at least 3 to 4 differentials.
yes,
Mhm.
Okay?
but against also Dr. Dina will be the signs of, and again the intercare pressure. It's not associated with increased intercare pressure, right? But you're right. If you have obesity, it might be simply associated with OSA. And the good
Mm.
thing in this scenario, Dr. Yasser asked about the OSA in the history. Anyone told you are snoring?
Yes.
Just as a complication or as association of obesity, it might be there. One question you might roll it out, and one examination you might roll it out, and it's very important to do either this or that. If you do both, it would be perfect. But if you remember that, you might forget either the history or the examination. At least do one of them.
Yeah.
In summary, any obesity in the exam, any obesity, you have to ask for the OSA as a complication. Any
Yeah.
obesity, it's very important. Plus osteoarthritis, you can also add it here. If you have time to examine, you can ask for the crepitus in the knee,
Yeah.
as also complication of obesity. So carpal tunnel, obstructive sleep apnea, and osteoarthritis. These are the common complication and association for any obesity, even simple obesity. Okay, remember them in
Yeah.
any obesity. Put it in your tips that I should do these examination steps.
Yeah.
Yeah, thank you, Dr. Dina, for the comment and also adding stuff.
The last thing, I'm sorry. We
Yeah,
need to arrange the differentials for the case. So I
yeah,
should exclude any space occupying lesion, but other than that, I didn't find any focal neurological deficit.
Yes.
We need to exclude the sinus thrombosis, but against that, he didn't have, or she didn't have acute headache. Also,
Yeah.
what do you think about differential?
Also, you want to put it as differential?
The fourth one.
The fourth one, brain abscess.
Okay, second one, I mentioned space occupying lesion, whatever abscess or TB or lymphoma or any mass.
Okay, put the cancer.
Cancer, yes.
Pituitary adenoma also might be the case. The pituitary adenoma might present with signs of increase in tachycardia pressure.
Yes, pituitary adenoma, yeah.
Okay.
Okay.
Ready to start, Dr. Ahmed? We can
Yes,
start.
ready.
Okay, I will reset the timer. Okay, here you go.
Okay. Hello.
Yes, doctor.
My name is Dr. Ahmed, one of the medical doctor. Could I confirm I speak with Mr. John, 30 years old?
Yes, doctor, you are right.
Okay. Could you tell me regarding your condition?
Yes, doctor. I had the heart attack. What my family member said, I lost the consciousness. Then they brought me into the emergency department. The doctors take care of me, and I'm good now, doctor.
You lost consciousness, as you told?
Yes, I had the chest pain, severe chest pain, and lost consciousness. Okay, and I'm here.
Severe chest pain. This severe chest pain, this first time to have this chest pain? Or
Yes,
it has
doctor.
occurred before? Okay. How was the severity of this chest pain it was? If
It was
from 0 to 10?
more than the chest pain. Yeah. More than the chest pain, doctor. It suddenly, I get collapsed. Okay, and
Collapsed? Yes. Yes.
collapsed,
Okay.
and that's the reason my family members brought me here in the hospital. I didn't know anything. Then after the intervention of the doctor, I got revived. Doctor,
So you fainted out. You lost your conscious.
doctor, you are right.
Yes. Yes. So you have any previous history of loss of consciousness like this, or this is the first time also?
This is the first time, doctor.
Oh, because chest pain also first time. Okay.
Yes,
Regarding your past medical history, you have any past medical history? Should I know regarding any diseases you are treated in the past?
no, doctor. I'm not aware of.
Okay. You took any medications?
No, doctor.
You took any over-the-counter medication?
No, doctor.
No other recreational drugs that we have done, or
No, doctor.
no other previous operations also in the past?
No, doctor.
Okay. You have a history of high blood pressure,
No, doctor.
high blood sugar,
No, doctor.
high cholesterol?
No, doctor.
Okay. You have awareness of heartbeat?
No, doctor.
You don't have this. Okay.
Actually,
You have
doctor,
just yes.
my events were, I was having large meal. I was sitting in my sofa, and suddenly I lost my consciousness, and that's how I brought it.
Oh,
I was in the hospital.
okay. Okay. You have any weakness before?
Weakness before? No, doctor, not before.
No history of faints also before?
History of doctor? Faint? No, doctor. No
Faint.
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 No, doctor.
Or fits? Fits also no.
No, doctor.
You have any visual affection?
No, doctor.
You have any hearing problem?
No, doctor.
You have any stiffness?
No, doctor.
Okay. You have any history of fever?
No, doctor.
Any weight changes?
No, doctor.
Any sweating?
No, doctor.
Any bumps or lumps in your body?
No, doctor.
No eye changes?
No, doctor.
Skin changes?
No, doctor.
Regarding your bowel work, any abnormality?
No, doctor.
You have any abnormality in your water work?
No, doctor.
Any bleeding from any orifices?
No, doctor.
You have any family history of same condition or diseases run in your family?
No, doctor.
Okay. Are you married?
No, doctor.
No. Sorry to ask you this question. You have any extramarital relationship?
No, doctor.
Okay. What is your job?
I'm a teacher, doctor.
How much is these symptoms impacted in your job?
Yeah, this time it's very, very much difficult, doctor. And sometimes I'm having these cramping pains in my legs also.
Cramping
And
pain in your leg.
uh,
When this cramping pain in your leg is started?
yeah, this morning also, I was sitting in the couch after having heavy meals that cramping pains, cramping like sensation in my legs. Then I got this, loss of consciousness. I lost my
Okay.
consciousness.
You have any swelling in your legs before?
No, doctor.
Okay. The nature of this pain,
Which pain, doctor?
which
My
the cramping pain first?
cramping
Yes.
like doctor.
Like what?
Cramp like sensation in my legs.
In your legs, both legs.
Yes, doctor.
Okay. And the nature of the pain in your chest also?
More than a pain, doctor, I lost my consciousness.
Okay. Okay. Do you smoke?
No, doctor.
Do you drink alcohol?
No, doctor.
Do you drive?
No, doctor.
Okay. You have any recent travel history?
No, doctor.
You have difficulty of swallowing?
No, doctor.
You have any tummy pain?
No, doctor.
Do you feel sick?
No, doctor.
Any thrown up?
No, doctor.
Any change in the color of your bowel motions?
No, doctor.
Okay. This cramps in your legs, it come and go or it is persistent?
This time it persisted maybe for some time. Before also I used to have this kind of thing, doctor.
Okay. Okay. Before also you have this cramps.
Yes,
Yeah.
and it made me difficult to walk.
Okay. You have any mood changes?
Sorry, doctor.
Mood changes?
No, doctor.
No mood change.
No.
Okay. This symptoms and complaints, this is the first time to occur to you.
Yeah, heart attack for the first time, doctor. But this cramping like sensation before also I used to have.
The cramp is also it was before.
And the cramping like sensation before also.
Okay, this cramp is it occur after exertion or doing heavy work?
Yes, if I do some exercises, yes. Yes, it is more.
Okay, before this attack, you were doing heavy exertion?
This time, no, doctor. I had heavy meal and I was lying on my couch. That's how this event happened this time.
Okay. Can I know the vital signs and the body mass index of this patient?
Normal, doctor.
Normal. Okay. Okay. There is no change in the color of water work
No, doctor. Nothing.
after this exertion?
No, doctor.
Okay. Regarding there was witness while this fainting has occurred.
Sorry, doctor.
There is witness. Who witnessed you while this occurring?
My
This
family
attack?
member, doctor. Yeah. My brother's doctor.
Your brother.
Yes.
Okay. When this occurred, you wetted yourself.
Sorry, doctor.
You were wet when this
No, doctor.
occurred. You bited your tongue.
No, doctor. I'm not actually aware of that.
Okay. So there is any tracing of your heart done here at the AR?
Now, no, doctor. Now I'm fine. Okay, doctor.
Okay. When you get from your loss of consciousness, and you get, now your is the place you are here, and names of your brother and other family member.
Doctor. Yes, doctor.
You are
No
aware
problem.
of the surrounding and the time and everything.
Yes, doctor. You are right. I'm completely aware of it.
Okay. Okay. What is your concern?
So what happened with me, doctor? Why I'm having these symptoms? I have cramping like pain. Before also I had similar pain, and I had heart attack in the morning. Okay, after having heavy meal. What is
Okay. I appreciate your concern. We will do some blood tests, and we will do imaging for your heart, and also for the brain.
Mhm.
Is that okay with you?
Yes, doctor.
Because yes, yes. Mostly, we should be sure of your condition before reach to the final diagnosis. Because you lost the consciousness, we should be aware of your brain functions, and also this heart attack. Also, we should do tracing of your heart also, and imaging to be sure what has occurred with you.
Okay, doctor.
Okay.
So done with
And I should do examination first before the concern. Sorry, I want to examine you.
okay.
Sorry. Okay, I wanted to see vital signs. You told the normal. I will
Now,
check also by myself, and I'll ask if there is any shoulder pain. I will do the
Mhm.
collapsing pulse. Okay.
Everything is normal, doctor.
Okay. Then I will go to the heart auscultation.
Normal, doctor.
Normal. I will go to the back of the chest. Also, I will auscultate.
Normal, doctor.
Normal. Okay. I will go to the general examination for. I will see the eyes,
Normal,
the
doctor.
acuity. Normal. Okay.
Normal.
And also there is no jaundice, cyanosis,
Nothing, doctor.
pallor.
No, doctor.
Okay. Okay, I will do neurological examinations, the pronator drift,
Negative, doctor.
negative. I will do motor, one of the motor, the power.
Everything is normal, doctor.
Okay, sensation also normal.
Yeah.
Okay. Okay, I'll do the coordination also normal.
Normal, doctor.
Okay. I will go to for abdominal examination.
Nothing is there, doctor.
Okay. Next, there is no bumps or swelling. Rest GVV normal.
Nothing, doctor. Everything is fine.
Okay. Okay. Okay.
So what are your duties, doctor?
Mostly, you have a condition named as transient ischemic attack, where you will lose your consciousness for a while, and then you can regain this consciousness. But if this condition is occurred, we should be sure of normal your heart and your brain, because this is first time to occur with you, and the risk factors, you don't have smoking or other risk factors. It has not occurred before.
Okay, doctor.
Okay.
I think I didn't tell you properly, but this is the exam, my exam case, doctor.
Really, you examined this case before?
Okay,
Yeah,
Dr. Yasser, don't give him the case, and let's, if he finished,
Okay,
we can
listen,
start the
very quick.
examiner. Yeah.
Okay, this cramps while occurring to you before, you measured, they measured for you your blood sugar or your salts in your body?
Yes, doctor.
It
Everything
was
was.
normal?
I don't know. Blood pressure, sugar was normal, doctor.
Okay. Blood sugar were normal, but salt they have not measured.
Other electrolytes we didn't measure, but sugar was normal.
Mm. Because you may have also condition named as hypokalemic periodic paralysis.
Yeah, this is the case, doctor.
This is the case. It is difficult, really. But yes.
But I think I couldn't, I didn't answer you in a more way because at the exam, during exam, I had picked up very early. Because what
Yes.
he had told history of the heart attack in the morning and patient now in ER, then
Yes.
how did all those things I asked. And typical history, what the patient told me was, I was after heavy meal, I was lying in the couch after I had heart attack. During heart attack, before I had the cramping sensation in my legs.
Yes. Yes. Yes.
Okay,
Okay.
let's start the examiner question. Dr. Yasser, can you start?
Right, surrogate.
Okay.
Okay. Anyway, doctor, what are the differentials?
The first differential will be the hypokalemic periodic paralysis. The second differential, it can be also an attack of hypoglycemia. Blood sugar should be measured. The third differential also transient ischemic attack.
Okay.
Okay. The other differential also, it can be also myocardial infarction, because I don't know the nature of the pain in this patient also. I asked regarding the pain, he told me pain, but I don't know the nature and this radiation or something like that one. Okay.
What else?
The other differential, I don't know regarding also the blood pressure. It is normal now. Maybe also you have.
Before also
Yes.
normal.
Yes. So this is my 3 or 4 differentials that I have.
Another is thyroid periodic paralysis. Could be arrhythmias.
Yes. Could be heart block also.
Yes.
Yes. Okay.
Okay. The workup.
Work up for this patient, apart from CBC, RFT, LFT, also will make for him the cardiac enzymes important to be done. We will make also for him brain imaging. Okay. CT brain at least, or MRI brain. And also we'll do for him ECG and echo heart. Also for this salt is also sodium and potassium, calcium.
Yeah.
Electrolytes important. Also we will measure his corticosteroid in the blood also, cortisol.
Okay.
Yes, and the blood sugar important.
Yes. Yeah.
Yes. Also saying we can because it may be also but he will have tummy pain or something, DKA, if like DKA or something, but he should have tummy pain. But at least we will measure the blood sugar also.
Good.
Okay.
Okay, doctor.
Okay.
And how will you manage?
Management according to each differential we will manage. We will have the non-pharmacological and the pharmacological. The non-pharmacological will depend. We will need to increase the salts in the food, and we will avoid vigorous exercises. And they will provide the food rich in potassium, like a banana.
Okay.
The pharmacological will depend on the serum level of the potassium. We will give the IV potassium, but also we will monitor his ECG because of the hyperkalemia. If I correct, hypokalemia can enter into hyperkalemia and this arrhythmias. Okay, if this is okay. if this is periodic hypokalemic paralysis, okay. If it is a heart block, also according will be multidisciplinary, including the cardiology, and they will manage accordingly.
Okay, doctor.
Okay. Also, the other measurement of the blood cholesterol should be done also, because it may be a transient ischemic attack.
Okay.
Okay, he will need antiplatelets to be given for him, because still we don't know the diagnosis. Yes.
Okay, doctor. Thank you, doctor.
Thank you.
So let's have opinion from other
Yeah.
doctors.
Yeah, please comment first on Dr. Ahmed performance. Then we can hear about the case.
I think these things was differentials was I think it was not in his mind. So initially he got a bit disturbed. So history, analysis of the symptoms. I was trying to give him that clue, cramping pain and previous history also. I think he missed in that part. But when he got it later on, that is okay. And other things were fine. Doctor. Other things were fine.
Okay. So what about the main complaint? How they wrote for you? Heart
Yeah,
attack?
the same doctor. This is like I wrote it in the
Really?
same way.
They put in the complaint, patient
Yeah,
present with
combined.
heart attack,
Yes, heart
and
attack
they
in the
want to
morning.
know, yeah, they want to know what are the causes of cramps or the leg pain.
Even
What's the relation between heart attack and
history of the heart attack. Now patient in the ER. Then once I explored, then he was telling the cramping pain. Previous history also. It
so
was
it's not the main complaint. He was having heart attack earlier, but now he present with another complaint. This is what you want to say.
no doctor. Whatever I have written, the history of the heart attack, the patient is revived now in the ER.
Okay, so the first thing you ask him, what is your complaint? He
Yes.
told you, I have
At,
cramps.
yes. At the first instant itself, what he said is, yes, I had a heart attack. Now I'm okay. I had to have the heavy meals. I was lying in the couch. Then at the time I lost my consciousness, and at the similar before this attack, I had a little bit cramping sensation in my legs.
Okay, and then you analyze the legs or the leg
Yes.
pain.
Yes.
It was bilateral and it was happened as
Bilateral,
sudden.
yes. Previous history was there.
Okay,
Then other things, everything was negative, doctor.
everything was negative because now he's cured or it improved.
Yes, now improved, and the
He
vitals were
doesn't he
all the
doesn't
exam normal.
he doesn't have any thyroid problem.
No thyroid problems. No,
No goiter.
nothing, doctor.
What about the examination? The tone, power, reflex of the legs?
Everything was fine, doctor. I did 3 examinations and the lower limb full neurological examinations. I did tone power reflex, even the sensations coordinations. I did it. Everything was fine, and heart, lungs, and carotid artery, and pronator drift also I did. Everything was fine.
Okay, what about the heart itself? Any cardiac issue in this scenario?
No, doctor.
How they will evaluate on your performance in this case?
I don't know, doctor.
Did you receive the feedback or already the
No result.
marks?
I'm waiting for the result, doctor. This is
Ah,
like
okay.
March and April 12 in the Abu Dhabi case.
Okay. Abu Dhabi periodic paralysis.
You
Okay.
had this case in your exam?
Yes, doctor.
Yeah. Hypokalemia, yes, coming with these cramps.
Yeah.
Okay. Why you didn't mention to him that you can't move your legs? Any sign for paralysis? It came like that in the exam. Not
Exam
mention
it came
anything
like this,
about
doctor.
weakness.
Yes, it came. The complaint was history of the heart attack in the morning, patient now in the ER.
Yeah,
Okay. And
it's
the issue is that he had a time whilst he can't move his legs, يعني I mean some kind of weakness, paralysis.
No,
You mentioned about pain.
when he in the past medical history only, he gave he told those things. When I asked these heart attack things, then at the time, okay, I had heart attack. Before that, I had a cramp like sensation in my legs. I was lying in my couch.
Yeah, yeah.
That was the thing.
I know cramping means refer to hypokalemia, but I can't get the point while he can't move his legs. So I can say it's paralysis. So I will do full neurological examination to the legs. The case overall is, I mean, very hazy. I can't catch the main problem. So did you ask about any previous attacks like this before? What is
Yes,
the case? Yeah, and he gave you information.
yes. I had the similar issue before. Not heart attack, but this what is that? Cramping like sensation and the weakness before also. I gave him this history.
Mm. Is it preceded by heavy meals like that? And
Yes.
he had previous attacks. Wake up at morning, can't move his legs, or pain also in the legs.
No heart attacks, but there's cramping like pains and weakness was there.
Weakness and cramping, like attacks. Okay, and
Yes.
weakness. Okay,
Yes.
okay. And recurrent many attacks.
Yes.
Okay.
And yeah.
It seems like it's easy, and in the same way,
Doctor.
it's weird, easy and weird.
Yes, weird.
Yeah, but it's still as a case of exam, it's easy, and you can get marks because nothing in the finding. So
Nothing
you will
grinding.
not miss the mark and identify the finding because no finding. But
And
the
I gave
examination steps, yeah,
hypokalemic paralysis. Hyperkalemic paralysis could be thyroidotoxicity, but there was no thyroidotoxicity
yeah,
symptoms.
yeah.
And arrhythmia.
These are the differential, by the way.
Yeah.
He
These are
shouldn't
the differential:
exclude that.
hypokalemic, hyperkalemic, or hyperthyroid.
Yeah,
Yes,
and also I told, okay, will you admit this patient? He told, yes, doctor, I'd like to admit. And then why we went? So there is chance of the arrhythmias also. So water monitoring is
perfect.
required.
Yes,
Told
He should
that
exclude
level five.
medication.
yes,
What?
Sorry.
you're right.
Check the peripheral pulses. Check the back of the legs, the cuff
Yes, doctor.
for any
Yes,
DVT.
yes.
And the full neurological examination, I
Full
think.
neural. I did it. First, I started the examination with the lower limb, full neurological examinations. I did, doctor. Then I checked the heart, lungs, pulse, heart, lungs, carotid artery, pulse,
Mm.
Yeah.
and drift also I
So
checked.
it's like a gift to give you a
I
surrogate with this. Really, you can gain good marks in this case because you will get the clue earlier.
yeah.
What's
But first, like
what brought you to the
it's just
clinic
hard to,
today or the emergency,
yeah,
right?
yeah.
Then he
Like
will say, "Yeah, I had heart attack earlier. Then later on, I
no,
had this cramps or weakness in
no
my
previous
legs."
history of heart attack, doctor. This time only heart attack, but previous history of the cramps and the weakness before.
Okay, but the heart attack itself resolved totally,
Yes, total result.
and nothing here it can be signifying the case with the heart attack or
Yes,
the dyslipidemia, for example, or why he had the heart attack and why he had fainting. It's very
because of
weird.
the yes arrhythmia.
Perfect.
Yeah,
So the arrhythmia, yeah, lead to heart feeling of chest discomfort. So it will not be like heart attack. It should be as a discomfort,
yeah. That's why I told him.
right?
That's why I was trying to give the doctor clue. Okay, this is not particularly pain, doctor.
But
I
why he lost consciousness?
because of
Because of
the
arrhythmia. Yeah,
cardiac arrest.
arrhythmia can cause syncope.
Syncope. This syncope, not seizure or epilepsy. This
No, doctor, no.
The arrhythmia, one of the causes of syncope,
what?
by the way.
Yes,
You can
What?
put it as a differential.
cardiac
Yeah,
arrest actually.
Yes, the syncope due to arrhythmia. You're right. Cardiogenic syncope.
yeah, perfect. Okay, thank you, Dr. Yasa. It's a nice case. Weird, but nice. Still
Exam
challenging
case,
one.
doctor.
Yeah, hopefully you will pass, inshallah. And you will tell us about your feedback soon with the success,
Don't know,
inshallah.
doctor. Other didn't go well, and
No, no worry. You are doing
I
well,
got
by the way. If
I got this on admission document also, doctor. Today, that's why I was worried. So what to do? Let's do the. I
no,
have
no, no,
no.
it's okay. No, it's okay. They can give you again. It's okay. Forget about it. Just focus about the current and let us know whenever, inshallah. Hopefully you pass.
Don't
Okay,
know.
I want to thank you, Dr. Ahmed. Yeah, hopefully, inshallah, you will pass. Let's
Inshallah.
comment on Dr. Ahmed history and examination. I think Dr. Ahmed still your history is not even the case is weird, but you're asking question from here and there. I want you to be more organized and systematic.
Yeah.
Believe me, they are focusing and commenting about everything, and it might harm your clinical communication skill marks. If you
Mhm.
ask in this way, you ask, for example, constitutions, then the history, then social, then systemic review,
Yeah.
it
That.
will harm the marks. Yeah.
So in this case, I should ask first what I ask the cardiology and the neurology. Then I went for the 10 questions. Then past
Uh,
medical, then past surgical, family, social. Then I return it back to the other system. So
okay. You ask the system area relevant,
I
which
asked cardiac and the neurology.
okay. Yeah. So you ask. I thought you are asking systemic review earlier, really. But
No,
now
no,
I
no. I asked
realize. So
cardiac
you ask
neurology.
about relevance because he has two symptoms. So you ask
Yeah.
about two symptoms, so two relevant system. Okay,
Yeah.
that's why
Yes.
you ask for the systems and then back to the. Okay, I got it now. Yeah, I thought you are asking systemic review when you ask
No, no, no,
about
no.
the
I asked.
systems.
I see
So
the
it
complaint either cardiology or neurology. I don't know.
CNS
So I
as a
asked both.
syncope. Yeah.
Yes.
Okay. Okay. Yeah. At least you know the case at the end,
Yeah.
and yeah, it's not easy. Really, easy one.
Yeah. Not easy. But I don't know. At that time, it just clicked. Maybe at the first instant itself, it clicked. Like when he told me the cramping,
By the
then I
way,
thought that.
yeah. By the way, most of the exam case you might know the case, but the way
Yeah.
how to approach
Yes.
this is
This is a.
the yeah this is what they are judging on.
Mm,
So most of the surrogate they will give you the clue,
mm,
but
mm,
how to systemize and to be organized and to reach to the diagnosis, ruling out other differential, examining the approach itself will be judged on.
mhm,
This is the difference between who get the diagnosis and he did it in this organized way, and the other doctor he didn't know the diagnosis, but he did the approach properly,
mhm.
and might be the second candidate might pass, and the
Yeah.
first candidate who knows the diagnosis didn't
Might.
pass. Yeah,
Yes. Possible.
exactly. Yes, you're right.
Sorry, Dr. Bassem, I wanted to ask regarding if I have a patient in ER. First, I should ask regarding the vital signs if he has not give it to me, I think, before starting any,
Yes, yes.
isn't it?
This is
Yeah.
like a general look. This is like general look.
Yes.
May I know the vital signs of this patient?
Mm. But
Why?
it will be given, doctor. It will be given like
Yes,
in.
it is in the paper, by the way.
Yeah.
I didn't say it is in the paper outside. But
Yeah.
sometimes they will tell you, no, the blood pressure now is higher or lower than the in the paper. And if the examiner is good, he will tell you like in your paper. But
Mm-hmm.
please write down in your paper that the vitals, all vitals were normal,
Mm-hmm.
and you have to, for example, underline. the abnormal reading. For example, if the patient is normotensive but tachycardic, you will circle this tachycardia, put it in your paper that this patient had tachycardia before going to the station inside. Why? Because if you didn't focus on this, maybe the examiner will tell you the vitals as outside. What was outside? I didn't remember because I didn't write the abnormal finding. So you have to write either the abnormal one, or you can, for example, put as capital letter N as everything is normal. Or the abnormal one, you can put it in the circle, like systolic pressure is high, tachycardic, febrile, temperature is high. You might ask the examiner, as I said, and he will tell you as outside, and you forget already what was written outside. So you might forget the temperature. And when you present the patient, of course you will not say that the patient was febrile. Why? Because you didn't remember what the patient written outside that he has fever. So focus about the paper written outside, about the vitals, about the complaint, put your scheme and follow the approach you are practicing through it. Clear now?
Yes,
Yes.
doctor.
Any comment, Dr. Ahmed, you want to, or any question regarding
No,
this
no.
case?
So the paper in the exam, I will not. It will be outside. So I will enter to the
Yes,
room. Yes, I may forget the. I should write on
exactly.
my paper before I
Exactly.
come in. Yes.
Yes. Yes. And don't forget to do examination. I don't know how you didn't examine the patient.
Well,
You
I
addressed
forget.
the.
Maybe I'm sleepy now.
Okay.
They told us regarding some doctors, they are forget to do the examination in the because of taking history and then asking concern. You may forget the examination.
No, no, no. You have to train what to do exactly in every session you are doing. So you will
Yes.
never forget the examination. It's 8 marks
Yes.
plus the welfare. The examination itself, as a physical examination, identify the finding, the
Yes.
welfare, all these steps in the examination. If you forget them, maybe you will forget around 12 marks.
Was the diagnosis.
Yeah,
Also,
of
maybe
course, the
depend on the
diagnosis.
examination.
But some
Yeah.
doctors or some candidate might know the diagnosis from the history.
Yes.
It's okay, you can know it, but the marks still from the examination, 12
Oh,
marks, yeah, might fail you if you didn't do the history well.
okay. What is also your advice, Dr. Bassem, regarding if I take history and the time is going and I have not reached a differential diagnosis? يعني, I will go
Yes,
to the examination at which time? Yeah, 9 minutes or
yes,
what I will
exactly.
do?
Maximum 9 minutes. You can
Okay.
start after that the examination. And by the way, no timer in the exam. So you will not look at your time, or sorry, your clock. You do even you might leave your clock outside or your watch outside. Even you cannot look at the clock in the station.
And time flies.
Mm.
Sorry,
And time flies in the exam.
exactly flies. You cannot feel it
Yes.
unless you are practicing in daily basis.
Yes,
So
that's right.
yeah, and try to make your training on less time. For example, if you are doing long on 15, do it on 13.
In
Adjust
7 minutes, you need to at least do seven, maximum eight, 7 to 8.
in in what in the communication.
No, no, doctor. History here in long case.
The history, yeah, the history. For example, yes, say 7 minutes. And by examination or with the examination, it's supposed to be 13 in your training. Why? You
Yeah,
don't know what will happen in the exam.
yeah. And if you take history properly in the systematic way, 7 minutes, it is possible to cover everything.
Per- Perfect. Yes.
Yes.
And forget about unnecessary question. Don't ask unnecessary. In this scenario, I don't. Yeah, but there is some copy also. You might ask about driving. Anyway, not in every scenario you'll ask all questions. Some question unnecessary. You have to remove it from your scheme.
Because the medical history is, if I'll ask what medication over the counter, recreational drugs.
Yeah.
It will take also time يعني. So
So ask them when it's related to the case. For
yes.
example, and in this scenario, I think recreational drugs
Important.
might be a cause, important as a same copy.
Yeah.
So you can ask this question.
Yes. I have also comment on his in
Yeah.
the history, how to make a history good and treat your diagnosis. Any complaint, you should analyze the relevant system, of course, the relevant system. So
Yes, exactly.
related to the leg. Ask about the neurological any weakness, any ultra sensation. Do you feel your legs floppy or stiff? And before that, there is general analysis for any complaint, onset, core duration, and any previous attack. Any previous attack can solve the issue here. Any previous attack, very, very important question, and make you think about two things, maybe MS, or if it's a weakness, multiple sclerosis, or hypokalemic periodic paralysis, and the triggers, okay? But the relevant system here is neurological system. Exclude any claudication also. Is it do you feel these cramps or this pain in back of your legs whilst walking or in exercise? Any previous clots? Exclude any DVT. And the differentials, I revised the Roch book for this case. Hypokalemic, thyrotoxic. You should ask the thyrotoxicosis question. Thyrotoxic periodic paralysis, and also the myasthenia gravis. Any doubling vision in Robin's islets. Don't. This is my advice. Don't go for any exam without knowing the differentials. You will not catch your kids.
Yes.
Differentials are very important. Expression cramping, and I revised the Roch. Roch is very simple and to the point, actually, I think so. But cramping is exactly to the hypokalemia. And also another clue in this case, I feel this weakness on whilst I work in the morning. I wake up with this weakness. This is a clue. But you will not catch these very precious informations unless you have a very good history and to the point. Any previous attacks, any triggers? What? The case is difficult. I was moving here and there, and I wasn't catching anything because the history was hazy. I thought it's like claudication due to the. I thought about hypokalemia, of course, because of the expression cramping, but
the presentation was just collapse.
You will not feel comfortable until you catch your case, actually. So make your history better than that by general analysis for any complaint, onset, course, duration, any previous attacks. This is general, and specific analysis for each complaint. Relevant system, of course. General question should be asked there, and the differentials for your case. For your case.
Exactly.
Yeah.
Thank you, Dr. Dina. Thank you, Dr. Yasser. Any comments or suggestion? Thank you, Dr. Ahmed, as well.
Thank you very much.
How I generally do is in exam, like before that, I asked 2-3 questions. So any previous history?
Yeah,
Any
perfect.
medication, skin rashes, flu-like illness. I ask these 4 questions, and I'll go for the complaint analysis.
Yeah, perfect. But sometimes it's not positive. It might waste some time, but it's okay. It's maybe positive in some cases.
Yeah.
The good thing, Dr. Yasser, your center is benign center. So
no doubt.
yeah, believe me, the whole Gulf are better than some other toxic centers. Really, you're from India, right?
No, I'm from Nepal, doctor.
Nepal, okay. But what I know, Indian centers are very toxic.
Nepal center is also very toxic, doctor.
Nepal, really?
Yeah, very, very toxic.
No.
Pakistan Pindi center is there when
Pakistan, some centers, not all centers. I hear some Pakistan center, yeah. Anyway, Abu Dhabi as a center is kind of
Don't know.
benign.
Let's see the results.
Yeah, okay. So that's reassure us when you know the results. Okay.
Okay. Thank you.
And we'll be happy for you and your success, hopefully, inshallah.
Don't know. I got the admission document, so I think I failed.
No, 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 no. Not necessary. Some doctors will receive the admission and they give them appointment, but still they pass them. It's not necessary. So don't judge. Just forget about it. Enjoy your time.
No,
Why?
doctor. I
Because
had called today.
sorry.
I had called them, and they didn't say. Actually, I was thinking that they will get the admission document on Friday, because exam is on 24th. Na? Normally, we get 4 weeks
Uh-huh.
before. So I didn't get. We didn't get until Friday. So today I called them. Then after calling them, they checked. Okay, then we are sending you admission document. Then I came to know I failed. So let's.
No, 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 no. Don't think like that. Don't think like that. Just enjoy. As again, enjoy your time. You pass, you will be happy. If not, at least you enjoy this month because again you will be in stress. So don't think about it. Enjoy this month with your family. Enjoy your time. Why? Because maybe, hopefully, inshallah, you will pass and you will be more enjoying.
No,
But if not, at least you enjoy that this month.
yeah,
Okay,
that's
forget about it. Forget about it, and hopefully, inshallah, you will pass. And you will tell us about your feedback and pass successfully, inshallah, soon. Thank you, Dr. Yasser, for attending with us. And hopefully, you can tell us also about your other experience, communication. If you have time, join us and tell us about your cases. Or you can present the communication tomorrow with anyone.
yeah, yeah. I'll do tomorrow, Doctor Communication.
When is your
Oh, okay.
examination?
My exam is 24th, Doctor. This in Dubai.
Okay.
Yeah.
Good luck, inshallah.
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 Thank you, Dr. Ahmed. I think there is some. Yeah, the Egypt Center very malignant. Agreed. Very toxic one. But before
Okay.
it was good, Dr. Dina. I believe a lot of doctors passed from Egypt. But recently, I don't know, maybe after.
Alexandria, you have an idea, Dr. Basim, regarding, because I will examine 31 this month also.
Best of luck. Actually, والله,
Okay.
don't about it. Don't think about it.
Okay.
Just do your best. Hopefully,
Uh,
you will. By the way, it's a matter of luck.
Okay.
Good luck,
Really,
yeah.
yeah.
Very much.
Okay.
Either you will have good cases with good examiner, and
Yeah.
hopefully you will pass, or you have good cases with even toxic examiner, still you can pass. But the worst is bad cases with
Very
toxic examiner.
Yes.
Yeah. So I pray for your luck to be good in that day.
We hope, inshallah.
Yeah, yeah. Because if you practice the cases you face, really you will do it in perfect way. But if you didn't practice them previously in your sessions or training, you will
Yeah.
be stressed and panic, and you're not doing them in perfect way. So hopefully you will have the case that you practice already, and you know what the thing you will comment on, what the question you ask, what the answer you address. You got it.
Yes.
But if you face a scenario in first time in your life, you'll be in trouble. What to do, what not to do, what to say, what not to say. That's why I'm saying good luck and good cases plus good examiner. This is the best luck ever. But the worst
Yes.
luck, if you have bad cases with first time and toxic examiner,
Yes.
definitely, yeah, it would be more difficult.
We will pray for this.
Yeah, hopefully, inshallah, all of you will pass.
Inshallah.
Inshallah, yeah, Dr. Dina said. Yes, forget about it, Dr. Dina, and hopefully next time will be your day, inshallah. Any comment from others before ending the session?
Appreciate it really, Dr. Basim. Thank you very much.
No worries, Dr. Ahmed. Anytime, if you are interested to practice, your exam is near, so you have priority now. It's less than or 1 month exactly. Yeah, 1 month.
Yes,
Okay. So you have priority anytime. Just send me if you want to practice.
thank you very much. Thank you.
Thank you. Thank you. Thank you, everyone. Thank you, Dr. Yasser, for joining us today. See you tomorrow, inshallah, with another communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام ورحمة الله.